Okay, great. So we're sharing the slides from this. Are you able to see it in presentation mode, the main slide? Is that all right?
I see it in presentation mode, yeah. And
Okay,
I
great.
think we're already live on YouTube, so I think we
Okay,
can.
great. Okay. Yeah,
Okay,
whenever you're ready. Yeah.
okay, okay. So thanks a lot, Anuraj, Anita. It's really a pleasure having you here, both in the morning and now giving a lecture to this partner, this university. It's two universities in the country, outside the capital of São Paulo, Unifaz and Unimax. There are our great partners in this big project called CISM, National Center for Research and Innovation in Mental Health. So I will introduce both of you in Portuguese because people
Great.
think are more familiar, and then you can begin. I think we have captions translation, right? The technical team already started that,
Okay.
and then they will have able to understand. Então, pessoal, não vejo vocês, mas é um grande prazer. Meu nome é Arthur Caio. Para quem não me conhece, eu sou psiquiatra, trabalho junto ao CISM, né, o nosso parceiro com a Unifaz e a Unimax, um grande centro de saúde, pesquisa e saúde mental. E nós temos aí uma parceria e temos um convidado internacional por semestre em média, né? E hoje nós temos uma dupla muito bacana, muito legal, que é o Dr. Anuraj Shankar e a Anita Shankar. São dois grandes pesquisadores. O Anuraj é líder da unidade de pesquisa em saúde comunitária da Universidade de Oxford, Indonésia, em Jakarta, e é parte do Centro de Medicina Tropical e Saúde Global da Universidade de Oxford, no Reino Unido. Então, o Dr. Anuraj pesquisa, tem centenas de publicações em trabalhos de biomedicina, política de saúde. Um dos temas centrais é a regulação e a resiliência dos sistemas complexos no nível biológico, comportamental e pragmático. E o Dr. Anuraj conduziu vários ensaios clínicos randomizados em grande escala, estudos de corte que examinam o impacto da nutrição, diagnóstico, vacinas, saúde digital sobre a saúde materno-infantil e o desenvolvimento cognitivo na primeira infância. E a doutora Anita tem uma trajetória em biologia, antropologia médica, uma série de questões envolvendo desenvolvimento, empoderamento feminino, violência de gênero, saúde materno-infantil, HIV, nutrição e capacitação de recursos humanos. Então eu vou dar a palavra para eles. É uma palestra brilhante, nós já vimos de manhã, e incrível e certamente modificadora para todos os profissionais de saúde, medicina e de outras profissões associadas. So thank you, guys. The floor is yours, and I'll be here if you need anything, technical issues with the English.
Okay, Arthur, thank you so much. So I'm going to go ahead and present first, and then Anita is going to go ahead and present after me. Okay, great. I'll go ahead and get started then. Thanks, everyone. Great to be here. So I want to speak with you about issues around how primary health care can really be enhanced. And that's why the title of the talk is Transforming Primary Health Care Delivery and Impact from Surviving to Thriving. And again, as I mentioned, the basic idea here throughout the presentation is to understand that what we're currently doing in primary health care, while potentially useful, is useful in fact. In fact, there's a lot more that we can be doing with primary health care. So a lot of the work I do is in Indonesia. So I just wanted to highlight here some of the issues in Indonesia. I see the slides are a bit offset here in some way, but Indonesia, as many of you are aware, it's the fourth most populous country in the world, 278 million persons, but it's an archipelago country, so it's spread across 17,000 islands and 550 districts or regencies. So it's a decentralized government. So there is, of course, a central government structure, but in fact, each of these 550 districts has some autonomy. And it's an intermediate income country, just like Brazil. But one of the interesting things, this last bullet point, is in fact, they have universal health care, national health insurance since 2014. Currently, that's covering around 240 million persons, is considered the largest single payer system in the world at this time. So, of course, some of the challenges in Indonesia relate to maternal and newborn health. And you can see here some of the health statistics there in terms of neonatal deaths, infant deaths, and so forth. And I want to highlight the point at the very bottom that I've listed is that there are gaps in the knowledge and skills amongst frontline health workers in Indonesia, like a lot of other countries. So it relates really to some of the things I want to talk about today. So this journey actually begins with this study that we did in Indonesia many years ago, actually around 24 years ago, the study began. And we were interested in understanding what was the effect of a complete nutritional supplement that we call maternal multiple micronutrient supplementation, or MMS. We wanted to understand the impact of this MMS compared to iron and folic acid, which was at that time the basic standard of care for nutritional supplementation in pregnancy. So this was a large-scale randomized controlled trial referred to as the Summit trial, and we enrolled around 31,000 pregnant women. And what we observed there was, in fact, this MMS supplementation to the mother reduced infant deaths by 18%, and reduced those deaths by 38%, in fact, if the mother had been anemic during pregnancy. And interestingly enough, the effect on survival was bigger in girls than boys. Now, these results were subsequently confirmed by other studies that were completed. And overall, this nutritional supplementation during pregnancy has been shown to result in, as shown here, this 19% reduction in low birth weight, 30% reduced risk of infant death at 6 months of age, and again, 15% reduced death in children in the first 1 month of life, to much bigger effect in girls. Now, the interesting thing about this work actually is that we had gone back to this population 10 years after the initial trial, and we were looking to see how many of these children we could find and to do some detailed health and cognitive assessments. So when we went back, we were able to find around 70% of them. So out of that 31,000 or so that were initially enrolled, I think there ended up being somewhere around 28,500 births. And of those, we found around 22,000 of them. They were all between 9 to 12 years of age. We randomly selected around 4,000 of them and did some detailed cognitive assessment. So the most interesting thing about this work was that you can see on the left-hand side there the biomedical risk factors, how they related to cognition. You can see in the sort of the orange type bars the overall impact of cognition on these different domains of cognition: general intellectual ability, declarative memory, procedural memory, executive function, academic achievement, fine motor dexterity, and socio-emotional status. So, as I mentioned, the biomedical risk factors are in orange. The psychosocial risk factors, or the socio-environmental risk factors, they're sort of in this blue and green colored bars. So there's sort of two things that were the takeaways from this 10-year follow-up. One was that the MMS supplementation did have a long-term impact on the cognitive development of these children, between 0.1 and 0.2 standard deviations of improved impact on cognitive performance of the children. But the other really interesting thing, in fact, was that it showed very clearly that the socio-environmental risk factors were typically more important than the biomedical risk factors were on child cognitive development. And this was really the first time this sort of analysis could be done because we had followed the children over time and collected both biomedical risk factors and socio-environmental risk factors. And particularly interesting is the socio-emotional status of the child. You can see how much that is really affected by the psychological status of the caregiver. In this, most cases here, it was the um, mother. So you can see if the mother was depressed at the follow-up 9 to 12 years later, if she reported as having been depressed at some point in her life. In fact, this had a very big impact on the socio-emotional status of the child. So this is really highlighting from the primary healthcare standpoint interventions that are having an impact on the psychological status of the primary caretaker are very important. Unfortunately, there's not currently in primary healthcare a substantial focus on that. So this study, the other interesting thing about this study that I wanted to share is that because it was a double-blind randomized trial that was integrated with the government health system, we were not actually delivering supplements to each pregnant woman. In fact, we had to promote community health in each of the villages so the pregnant woman would seek out care from the government health services. And the different government health services, the skilled birth attendants who providing antenatal care, they were actually randomized to distribute either iron and folic acid or the MMS. So it meant what we had to do is actually very much promote antenatal care in these communities. And at that time, the overall population of this island was around um, 2 to 3 million. It was 3 million individuals living there at that time. So we had to hire somewhere around 400 of these community health promoters. So we had, there were existing at that time community health promoters that had been hired in each community. And these are ones that had been appointed and selected by the head of that particular community. So each village, the village chief, for example, had selected these particular individuals. And at the time we did the study, I went to the provincial governor and I asked if we could, for the study, since this was so important, promotion of community health care, if we could in fact recompete all these community health promoter positions and in order to find ones that were highly qualified that could do the work well. So we did that, and we were able to hire a new set of community health promoters. And this, in fact, was very interesting because actually, in every village, the community health promoter that we hired turned out not to be the one that was already selected as a community health promoter by the government. It meant that in every village, there was someone who could do the job of being a community health promoter more effectively than the one who had already been doing that job. And the impact of that from a primary healthcare standpoint was very interesting. So here you can see that in fact, on the right-hand side, if you are a poor quality community, what we call a community facilitator or a community health promoter, there's actually no impact on the relative risk of death, of child death in these communities. Now, keep in mind that these ones would be similar, the ones that were poor performers would be similar to the ones, in fact, who did not get rehired in the open competition. So it meant that probably most of the existing community health promoters were not having much of an impact. But in these rehired ones, if you were average or if you were good, a good quality worker, actually the risk of death, child death in these communities went down by either 20% to 35%. So again, these are individuals living in these same communities, these sort of superheroes of public health that are not professionally trained health workers. They're just persons living in the community that were trained to promote good health practice in general. And if they do that well, it actually has a substantial impact. So again, one of the aspects of primary health care is probably there's under recognition of the actual capability and the presence of talented persons living in all these uh, communities. So our challenge then at this time was, how do we formalize this kind of process more? And so the team actually that created the summit trial itself, did all this recruitment and training of these workers, they actually formed their own NGO. They named themselves the Summit Institute for Development. And their focus has really been for the last 20 years on how to develop tools to interface with the community and optimize the promotion of primary healthcare and primary healthcare performance in the community. So one of the first things they did was they started thinking about how can we create digital health tools that will emphasize, that will enhance the ability of these frontline health workers. So they created this platform that is called Open Smart Register Platform, or Open SRP. And this is a open source digital health tool that is a information system for frontline healthcare workers where they can develop apps and use them to manage their clients. At that time, when we started designing this in 2014, there was no open source tool for this purpose. There were other health information systems like OpenMRS, for example, but those are sort of clinical or hospital-based information systems. There was nothing really for frontline health workers. So we had a group of coders actually in Kenya, in Pakistan, in Bangladesh, and in Indonesia. So we were able to develop this initial tool. And so um, we were able to deploy that tool to several different frontline health workers. So this is a snapshot I'm showing you here of the primary healthcare system in Indonesia, really from the district to the hamlet. So in Indonesia, at the district and sub-district level, there are these facilities that are essentially primary healthcare facilities. They're called puskesmas. And that's where you'll have doctors, midwives, nurses, vaccinators, and nutritionists. Below that level, at the village level itself, you'll have these other facilities called either the pustu or the pusling, and these other community outreach posts where essentially workers from the primary health center will go to a village or a hamlet once a month and provide these health extension services. So like antenatal care, vaccination, and so forth. So here you see these different workers, midwives, nurses, vaccinators, nutritionists, early childhood development specialists. They may go to these communities. Typically a doctor does not go. And then, as I said, at the village or hamlet, these are the specific sort of community extension activities that are done. And you can see here I've listed the types of health workers. So one of the challenges that the Summit Institute for Development wanted to assess and to try to solve was that all these different frontline health workers, they provide their services, but those services are not integrated in any way. So a family or a person, if they want to get these services, they really must approach each of these health workers individually. And this is what we refer to as provider-centered care. But what we really want is to transition that to person-centered care, where essentially the family is at the center on the right there. And in fact, every one of these health workers, frontline health workers, they have access to the care plan or the health record of different members of the family. So no matter where this family member goes, this health worker, whether it's early childhood development, whether it's a skilled birth attendant or someone at the village health post, that health record is known for each member of the family. The care plan is known, they're aware of that. So no matter where they go, this coordinated team of people is actually providing the care for that individual. So this is what we call integrated person-centered care. And it's very much driven by these different digital health tools. So the Summit Institute for Development, working with OpenSRP as the platform, created a network system of apps for these frontline health workers where they're able to share data across a care plan. So here I'm just showing you an example of 4 different apps, one for skilled birth attendant, another one for a vaccinator, and there was a nutrition app, of course, an early childhood development app. So all of these were sharing information. And these were developed in the context of what's called HL7 FHIR, and the FHIR stands for Fast Healthcare Interoperability Resources. And this is a data standard that is maintained by HL7, which is the Global Health Informatics uh, Standard Organization. And this data standard has been adopted by the World Health Organization, uh, who's recommended the policy that all countries actually transition to storing health data in the FHIR data standard. And certainly Brazil is one of the countries that has adopted this. So developing these apps on the FHIR standard really enabled all this information to be fully exchangeable. Now, this allows one to create the team-based care. And if you see here the impact of the team-based care deployment compared to in areas where team-based care was not deployed, you can see here increases in antenatal care, increases particularly in postnatal care, which is interesting because this is something, the postnatal care was something that was not being done. But in the context of the team-based care, every member of the team was aware that this was not being done, and they're aware uh, amongst each other that this is not being done. So in fact, they started to execute this work where they were not doing that previously. And interestingly enough, that had a substantial impact on child survival, which you possibly might expect because postnatal care is during that period where there's the greatest vulnerability actually for the child and the mother as well. And another interesting thing here is you can see that while um, these indicators increased, ANC4 visits, postnatal care, they're, they improve, which is great, but they still have a lot of room for improvement. So generally what we observed was that when a frontline health worker in primary health care receives a digital tool, they they do improve, but particularly if they were already a good worker or an average worker. If they were not a good quality worker, their performance did not actually improve much. So digital health is useful, but you need digital health with something else that enables that frontline health worker to perform well. And as I mentioned to you before, actually recompeting some of these positions to get persons more interested in doing that job is probably something that can be very important. And we'll hear about other interventions to possibly enhance the performance of health workers from Dr. Anita Shankar in the second part of this talk. So this team-based care is very interesting, and in fact, the Summit Institute won this award from World Health Organization a few years ago, with the team-based care being selected as one of the top 10 primary healthcare innovations at the global level. So again, this is this very interesting thing where you can create a team. These groups of people end up working together effectively. You get this emergent property of better quality care. And another interesting effect of this is because this was the creation of a digital tool around a WHO guideline. So here you can see a narrative guideline on the left of the World Health Organization for positive pregnancy experience. And the Summit Institute had created the apps to support that in the context of team-based care. This led the WHO to decide that for its policies, they should also release a digital adaptation kit that would guide the information system necessary to support a particular policy, in this case, antenatal and delivery care. From that, you can actually derive a app. We were able to design reference software that really places this policy into practice on a digital health tool. And that reference software can be locally adapted to each country and based on the HL7 FHIR data interoperability standard. So it's interesting to see how this kind of global change can occur from a small group of people essentially working in LMICs. For example, Indonesia can end up catalyzing a global change. So by having these different apps developed, they're implementing WHO policy. and based on the fire standard, you're able to create a system where all frontline health workers and facilities are on fire, meaning that they're connected. All their data are interoperable and they are connected. So this includes hospital data, primary healthcare data, and all the data collected by these frontline health workers. So it means the health record of this individual, in this case, a pregnant woman, is in fact um, uh, being populated by many different facilities and health workers, and all of them are able to see what her care plan is and what has been completed and what has not been completed. And this enables really her to get the best quality of care, again, with integrated team-based care. And as this information flows in, as you can see here in this diagram, on the left here you have the acquisition of information either through various apps, older apps the government might have, or through various health information systems, or on the lower part here you can see fire-based apps. All this information flows into a centralized cloud-based server, and it gets transformed into the HL7 fire standard if it's not already in that. And this comprises what's referred to in Indonesia as satu sehat, which means single health. So it's one data system where the health records and the submissions to this health record from many different sources actually is a single integrated health record based on the interoperable data standard. So that information then can be used to power various utilizations of the data. For instance, it can power a dashboard so people can see what is working, what is not working. So this is the public health data theater, for example, where dashboards can show which villages and communities are receiving proper care or not, possibly making recommendations of what should be done. And then likewise, you can use that data to power a call center or other support services. So the other innovation, in this case for primary healthcare, again from the Summit Institute, is creating what's called dynamic worker support. So what this is essentially is just like when you order a Uber or you order a meal from a restaurant, you can actually see that meal being delivered to you. So we felt like, well, that's a standard thing that's being done. Why not health workers? Also, community health workers, if they can be on such a platform where they can receive specific assignments and they can be tracked by a coach who's helping them to go out, reach particular households, find certain clients, and if there's any concerns or any additional help the clients need, there's this coach on the back end that can help them. So this is what we refer to as dynamic worker support, being able to, again, track and support all community health staff. And this is one of the examples of a message. So remember I showed you before here that a call center and other support services are powered off of all the data that is submitted. And what you're able to see there then is that what care was not delivered. So in fact, a pregnant woman, for example, would receive an update, something like this, that, hi, thank you for your recent visit to the health center. And these are the results of your antenatal examination that you did, and basically giving them this information that is customized. Here I'm showing this fields 4, 5, and 6. These are not the actual numbers, but these would be populated by the actual assessments that were done. So this would be customized text message, and she can also see her any results of laboratory assessments, and she can see whether or not she did not get a laboratory assessment that she should have gotten. So from this, we were able to see, in fact, that if a woman, a pregnant woman in this case, was aware of care that she did not get, she's able to go back to the health center and ask for that. Or maybe on her next visit for antenatal care, she's able to say, last time I was here, I did not get care X according to this WhatsApp message that I received, and I would like to have that care. So when we do that, if we have this study here assessing places where being supported with getting these WhatsApp messages, which is without. You can see these various essential services go up. This is hepatitis B surface antigen assessment during pregnancy, which is required. This increases, goes from 60 to around 85%. The PMTCT, not all women have HIV or HIV positive, but you can see there, if they are, that goes up about twice as much. Interesting thing here, you see glucose, which was not being assessed in this population, but those women that did receive a text message, they're able to go and ask for that. That goes from almost 0 to about 95%. So it's amazing, these sort of simple things that can be done to enhance primary health care, these sort of amazing effects that you can see from that. Another fascinating thing that we can look at is we can integrate other capabilities in with these apps. So in this case, here's a technology called OptiBP, which is optical blood pressure assessment. And what this is you can place your finger over the camera of a smartphone. You can launch the app, and the app will actually track the blood flow with each heartbeat through that's coming to the surface of your finger, and will generate this basically it's photoplethysmography, this waveform here. And based on the inflection points of this photoplethysmography, your blood pressure can be calculated. And so this takes around 30 seconds to take your blood pressure. And we were able to validate this tool, in fact, for pregnancy. So on the right-hand side here, you can see that, sorry, the graphics here sort of overlapped a bit, but you can see here the green zone here relates to what's required to qualify for the ISO standard, and the performance of this OptiBP certainly is within the green zone, whether the woman has ordinary blood pressure or whether she's hypertensive or whether she has preeclampsia. So it means that this sort of tool, again, can be very important in the context of primary health care if digital tools are being deployed. Now, there's also an additional added value of this, which I want to show you. So you can see this waveform here, this photoplethysmography waveform. And so you can actually, oh, looks like I'm able to run this, maybe. Let's see if you can see that functioning. Let me just go on to the next slide. So here you see this, the photoplethysmography, the waveform here, the signal. So we were interested to see if there's further added value we could get from this by understanding the heart rate variability patterns. But the signal maybe was not sufficient enough in quality to actually measure accurately heart rate variability. So we thought we could apply maybe another approach to that, referred to as symbolic dynamics, which representing heart rate variability as a set of symbols. So essentially what we do is we take a interval between heartbeats, let's say here, this interval here, and we just ask the question of whether or not the previous heartbeat is shorter or longer than the current one. The previous interval is shorter or longer than the current one, and with the next interval is longer or shorter than the current one. And then we just assign a symbol for that. So for instance, here, maybe an A might be assigned, and then we would go on to the next interval, ask the same question. So you can see we have different symbols, either basically A through I, that are assigned depending upon the previous beat was either longer, the same, or shorter than the current beat, and whether the subsequent beat interval was longer, the same, or shorter as well. So if you do that to a waveform, you get something like this, and you can see that you generate certain certain patterns, different words emerge. So in this case, you can see over like a 1 minute recording, essentially, you see the words GGG emerge, GIC emerge, FIB, etc. So these are all essentially variability patterns of the heart rate variability. So it's not the heart rate, it's not the heart rate variability, it's variability patterns of the heart rate variability. So and just to show you how this is not just some science fiction thing, that in fact you can see here, if you just randomly assign these same codes, if you randomly select them, these words do not actually emerge. So this is sort of a real type of hidden pattern in heart rate that's interesting. But is this really useful for anything? So one thing we can do is we can analyze whether or not these words themselves are associated with any sort of clinical condition. We can also examine how these words are connected by saying, well, GGG is connected to GIC through FIB here, and we can make a network connectivity map of that. So here you can see a network of the connection of the words themselves. So basically, if you take a normal person on the right here, you can see this connectivity of the words themselves. And this connectivity pattern shows that the different forms of heart rate variability, the variability of the variability, are connected, well connected in a normal individual. So for instance, if there's a variability pattern assessed here and the person's undergoing, let's say, illness, and this variability pattern up here is the one that's important to support their physiological functions, they're able to transition through these different variability patterns fairly well because they're connected so well. This different parts of these different patterns are connected well. On the other hand, if you're an obese person, the connectivity across the different variability patterns is not as good. So for instance, if you're over here and this sort of a variability pattern is required for you to adapt to some challenge you're having, in fact, you have to transition through all these other variability patterns. So this sort of information is hidden information from a physiological standpoint, but again, is accessible, easily accessible through using a digital tool of some sort. Likewise, we're looking at other information, types of information that can be harvested that's potentially interesting from the primary healthcare system. So one of the things that is done routinely is there's a use of these rapid diagnostic type of tests that many of you have seen and probably have used many, many times. So our question was whether or not if you capture this information from a rapid diagnostic test, can you get added information from that? So we designed an app that can look at these RDTs, capture their image, and do some assessment of the signal that they're giving. So here you'll see, this is just the integration of the control line. You can see here integration of the actual test line. So during SARS-CoV-2, we were able to, in fact, use this to assess the antigen, the SARS-CoV-2 antigen RDTs. We were able to show, in fact, that the ratio of the test line to the control line was reflective of the SARS-CoV-2 viral density. And here you can see that pretty good association there, as long as the CT value was actually below 25. So the CT value is a separate measurement when you do RT-PCR, which is the cycle time necessary before you start to see a signal. So again, the lower the cycle time is, what's called the CT value, the lower that is, the higher the number of SARS-CoV-2 particles that there are. So this is interesting because here we were able to observe in Indonesia, and it's subsequently shown in many other countries, that actually when a new wave is emerging or emerged during the pandemic, so in this case it was the Delta wave, you can see that the CT value when you're doing PCR between these spikes in the SARS-CoV-2 transmission, you would see that typically the CT values that you would get from a patient, even if they were positive, were high, which means the viral loads were not very high. But actually, at some point when a new variant emerged, you would start seeing people that had a higher viral load. So the CT value would go down. And interestingly enough, I've shown here in blue on the top the proportion of CT values below the average. And you can see here in blue here, that starts to increase. It goes up and it goes down. In the red here is shown the actual clinical cases of SARS-CoV-2. So what you can see here, in fact, that the CT values actually go down, which means viral load is going up in patients that are sick. And that starts to be seen actually 3 weeks before there is a peak in actual clinical cases, large numbers of clinical cases of SARS-CoV-2. So we use this in Indonesia, and other countries did also, to start to understand when it's likely that a new wave or a new variant is emerging. So the question we asked ourselves was that, well, if we can see this by looking at CT values, can we in fact see this also by looking at the C to T ratio, control to test line ratio on a RDT? And so this is simulated information based on the data you see above here and based on the correlation that you see here between the optical density of the lines and the CT value. So what this is saying is that if we had been able to harvest many of the images, or if any country or any primary healthcare system was harvesting these images, then in fact, just from that, you would be able to detect that in fact there was a change in the epidemiology of SARS-CoV-2 transmission. And just from the RDTs, you would be able to know that yes, a new wave of transmission of a new type, either the Delta wave or another variant was emerging. So again, it's this use of these RDTs in primary healthcare, sort of the all for one and one for all assessment. Let me skip over these. So the idea then behind this, these different digital tools, is we can put together this comprehensive data platform for research and acceleration of program impact. We call this the next gen principle, where essentially all frontline workers are equipped with key digital health tools, and they're able to therefore use this data accurately for decision making, both at the frontline health worker. When that worker is seeing clients, you can generate the team-based care, and this data can be used for many different purposes to enhance care delivery. So it's active use of data for action. And this enables you to create what we call next generation primary care and what we call scalable public health empowerment research and education sites, or spheres. And these spheres really empower health workers and clients with data for action. And you can apply analytics and AI, which I showed you some examples of, to discover disease trends and understand how you can really provide precision public health interactions. Also enables you to train public health practitioners in data-driven public health practice. And you can also deploy interventions at scale in 3 months or less, large-scale RCTs, which are important for understanding translational public health research and policy. So that gives you an idea of really this enhancement of primary health care that can be done. So I want to show you one other thing quickly here. This is an activity that we created called the Genomics and Science Dojo to accelerate action and outputs, and really teaching people how to have debates around information to try to reach a conclusion by open discussion. And this was created essentially through collaboration with Dr. Daniel Fattori at the University of Sao Paulo, and also Dr. Felipe Argolo at the University of Bahia, and also University of Sao Paulo. So both of them had created sort of a dojo type activity in here in Brazil. And in conversations with them, we realized that this dojo approach could be expanded to enhance the ability of persons and scientists to have open debate, because we realized most of the scientific information discussion was not occurring. So decisions were based on evidence-based decision making, which still is the main way decisions are made today, not so much on evidence still, but teaching people that debate is important and giving them the skills for that. So the dojo concept is essentially creating a safe place where debate is expected, and doing this sort of this intellectual combat by policymakers, health managers, and scientists to improve decision making. So the dojo approach is essentially creating this intellectual combat sport or technique that we call shinjitsu. And it's based on doing sparring, scientific sparring. And we teach people in the dojo how to integrate knowledge and critical thinking, deploy positive psychology and empowerment, and talk and talk and promote ideas in a persuasive approach. And we deploy the dojo in specific sprint cycles. So here I'm showing you examples of dojo sprint 1, 2, 3, and 4, which we did actually earlier this year. And in fact, in each dojo session, participants receive materials. In this case, it was on genomics and also science, but materials also on personal agency and empowerment. And they go through sparring. There's very specific exercises they do for sparring. Here's an example of the dojo sessions we did initially. Dojo session 1, breathing and mindfulness exercises, just like you would sort of at a regular sort of karate training and so forth. And then, since this was the genomics and science dojo, we reviewed sequencing technologies, an overview. But then we went through an interesting session, which we call the vulnerability session and information gap exposure, where they would talk about what they knew and didn't know openly in sort of a sparring session type of approach. So this was getting them used to the idea of being vulnerable in discussion and being open to sharing what you know and what you don't know. Then we went to Dojo Sprint 2, again, more sort of physical exercises. We did stair climb, breathing and mindfulness exercise. And in terms of the sparring sessions, we focus on critical thinking and effective communication. So again, you're developing these tools through sparring sessions, essentially. And then Dojo 3, we did an exercise how to be mentally focused by doing sort of simulated boxing striking, where someone would sort of create a strike, sort of a mock strike toward you, and you had to put your hand up to prevent that. So it's helping you to focus more. So again, sort of linking up these things between an intellectual combat sport versus an actual combat sport. Then we do lightning round of presenting and defending ideas and so forth. And then after this, we actually held a dojo tournament. And this was the type of a tournament that we would establish. There would be Team A and Team B here. Team A would present their idea. Team B would then challenge that. The judges would assess this in real time and award points. In real time, you would score points, and whichever team scored the most points would actually win a match. So you can see here, as I described, in round 1, 8 minutes total. Team A presents for 2 minutes. Team B then challenges them for 6 minutes. Then there's a break, a 1 minute break for coaching. Then you come back in round 2, where the other team, Team B, presents, and Team A challenges them. And this is how a match is done. And we actually did host the first Shinjitsu tournament in the world in Jakarta. Very interesting. And this really enabled people, students, professors, senior researchers, to actually join in a tournament together. And interestingly, a doctoral student, actually the doctoral student that I have, his name is Edward Sutanto, he actually prevailed in the tournament. So he's the first global Shinjitsu champion. So we plan on expanding this approach more. Would love to establish this type of science dojo in Shinjitsu in Brazil. This is a video, but I think I'm not going to show this. So I want to thank all my collaborators, many different people working on these things. And I just want to call out specifically Dr. Daniel Fattori and Dr. Felipe Argolo, who really contribute a lot to the work we've been doing in collaboration here in Brazil. So thank you so much for that. With that, I'm going to turn it over to Dr. Anita Shankar.
All right, thank you. All right. I am going to now share my set of screens. There we go. Hold on just a moment. as I come to this. All right, here we go. Well, hello everyone. My name is Anita Shankar, and I'm going to be talking about how we can use the power of personal agency to transform healthcare delivery. And Dr. Anuraj's discussion, he talked a lot about how we can enhance information to healthcare delivery teams so they can optimize and improve how they give care. What I'm going to be talking to you about is how do we actually help those folks on the ground to be able to enhance their own ability, their internal ability to be able to effectively work and improve their lives as well. So, what is the challenge? What the challenge is in primary health care, in order for it to improve, it is absolutely critical to empower both the frontline workers as well as the populations themselves. And what research has shown is that this idea of personal agency is central to empowerment and required for behavior change. However, there is a lack of interventions that actually incorporate evidence based personal agency approaches into their development or health programming, even those that are designed to be empowerment initiatives. So, what is agency? So, the formal psychological definition is the ability to define one's goals and act upon them. But oftentimes, when you hear about agency, you hear many different terms like self reliance, capability, empowerment, goal setting, self determination. What we want to focus on today is this idea of personal agency. That is the internal psychological capability to envision and navigate towards a positive future. So, how does personal agency impact outcomes? Let's take the case of Nikita. She's a healthcare worker, and you can provide her proper nutrition, money, information through apps, electricity. You can even send her to school and be able to be trained in many different technical skills. But does that mean that Nikita will have the empathy or the accountability to work in her job effectively? Will she be attentive to the patient's needs? Will she be able to be innovative or respectful? One doesn't know, because oftentimes how we are in our jobs is impacted by the beliefs and the experiences that we have, including our psychosocial emotional states, our thoughts, the impacts of our past behaviors on our ability to do things in the future. In addition, we often have the mental models that we have created through our social relations. So, what we're capable of doing, how we should interact with others, is often developed through how we have learned to work with other people. So, I lead the Self Empowerment and Equity for Change initiative at Johns Hopkins University, where our mission is to catalyze agency in international development. So we generate evidence, we scale practice that includes a global cadre of agency facilitators, and enable innovation. So we actually look to see in the research, is anybody really focusing on personal agency interventions? We identified over 4,000 papers that had used the word agency or agency adjacent terms in the area of entrepreneurship, gender equity, environmental sustainability, or with healthcare workers. And then we narrowed it down and found 32 to review. However, only 3 of those studies had interventions that explicitly focused on personal agencies. But we want researchers focusing on this more explicitly. Some of the additional results from the scoping review were that most of the efforts around personal agency were in entrepreneurship and gender equity, not in health. There were some that focused on sustainability, but those were focused in high income countries. Mostly, these efforts were targeted toward women, although we know that everybody um, needs to be able to learn how to enhance their agency. And while many studies discussed how agency might be related or hypothetically related to their work, no interventions were actually tested. So there is a lack of interventions supporting the development of personal agency. So, what are the kinds of impacts that we can see with personal agency interventions? So, the evidence that I'm going to be presenting to you was actually quite surprising in terms of the kinds of impacts we were able to see. This randomized control trial was done in Kenya with Kenyan cook stove entrepreneurs. And what we did is we split them up and randomly provided um, uh, half of these entrepreneurs with your standard business training, how to do records, how to create business plans, etc. And that was for 4 days. Now, for the other group, they got 4 days of only personal empowerment training. And with the graph on the left, you can see because being an entrepreneur can be quite difficult, there was a great drop off in the first few months. However, over time, it was those individuals who received the personal empowerment training only that actually continued to maintain their business, and that's depicted by the red line. The control that only got the standard business training, on the other hand, depicted by the blue line, dropped off considerably. So, a result of this randomized control trial showed that having just the empowerment training doubled the likelihood of you actually being able to maintain your business. With the graph on the right hand side, you can see that as they started off selling their cook stoves, it was quite difficult, and both the empowerment and the standard business training teams were going around the same level. However, when the local NGO decided to provide incentives, like buying the cook stoves at wholesale, there was a greater increase in individuals in the empowerment group that were able to take advantage of this opportunity and therefore sold more cook stoves. So it was those individuals who got the empowerment training that were more likely to take the risk and get the benefit from that. And overall, if you had the empowerment training, you sold 3 times as many cook stoves than if you just got the standard business training. We also, in another study, in a humanitarian setting in Rwanda, um, did this with a larger group of women and their male partners, and a really abbreviated training. This is only 2 days for the woman and 1 day for her male partner. And even within the context of a refugee camp, we still saw a 25% increase in starting a new business, a 34% increase in improved income, and a 60% increase in developing a new skill. In addition, if the male partners were trained, there was a tremendous increase in intra household task sharing, in childcare, doing the dishes, and making meals. We also found important impacts on gender-based violence. So we have about a 30% reduction in intimate partner violence for those who experienced it at baseline. In addition, we found a 35% reduction in non-partner violence, which from the qualitative research we realized was a result of them having better relations with their neighbors. We did not find any change in self efficacy or decision making variables, although we did see a slight change in self reported anxiety and depression. But again, remember that this is within a humanitarian setting, and there could be a number of factors that could be contributing to this. We also conducted a cluster randomized controlled trial in India where we included agency training with outreach workers who are working to reduce the it was basically the prevention of mother to child transmission of HIV in India. And what we found here is this agency training actually increased self awareness of these outreach workers. Their confidence improved, their interpersonal relationships skills improved, and that led to greater communication with patients. This also allowed the outreach workers to impart agency skills to their patients that help the patients make their own decisions more easily. We're also currently running a randomized controlled trial in 6 districts in Uganda with entrepreneurs for an adapted business and personal agency training. What I'd like you to also see is that what we have been doing around personal agency can be applied in a wide range of program activities, whether it's women's empowerment, environmental sustainability and health, or livelihoods and entrepreneurship. We think that personal agency is the missing piece to be having individuals take advantage of the opportunities, the resources, and the technical skills that they may have. And that's because much of why we don't take advantage of these opportunities is because of uncertainty, stress, and fear, or a lack of self esteem or confidence or doubt, as well as limiting sociocultural norms and expectations. So that's what our personal agency interventions are designed to be able to address. So let me tell you a little bit about what we do in our intervention. We first have individuals understand the relationships between our thoughts, our emotions, as well as our behaviors, our past behaviors, and how they influence our future behaviors. We start out with an exercise called the Tree of Life that helps each of us understand who we are in our life, what has our past contributed to our life, and also what our future goals are. Once we understand our future goals, we begin exploring what are the thoughts that I have that may be holding me back? And can I change those to move me in a direction that's more positive and toward the goals that are important? We also help individuals understand the basic values and core beliefs that drive their behavior. We understand that these types of mental models and thought processes and decision-making processes are not only within our workspace, but everywhere in our lives, in our relationships with our family members, our spouses, our children, our own health, our visions for our career, etc. So a wide range of every aspect of our life is affected by the level of personal agency that we have. So we really try to help individuals go from this reframing about what they want in their life to specific growth steps, those proximal steps that they can take in a short period of time that are helping to move them toward their goals. Now, we do this within groups of 20 to 35 people because that individual agency is supported by the collective agency for the group. These interventions can be done in very short periods of time with 16 or 24 contact hours. They don't have to be drawn out over months to be effective. The key, however, is to ensure that we have local trainers who can adapt this content to the local populations and challenges that are faced in the local population. And we use a number of dynamic methods, including mindfulness, visualizations, journaling, and we have a range of low literacy options as well. So the key aspect of our program is helping people sense, kind of gain awareness without judgment of how we're feeling and how we're seeing our lives, and then shifting our minds from negative thoughts to refocus on our strengths and potential in order to take proactive action toward the growth steps that we want and toward our work and life visions. So when you feel lost, you can become more aware of your thoughts in this cycle, um, and then decide on, okay, well, where do I want to go, and how can I reframe those negative thoughts, and then take actions to improve my situation. Now, we found this to be most effective when we pair it and integrate it with technical training topics. For example, um, with information for businesses or gender equity programs, etc. So we have worked in a range of different projects and populations. We have not had the opportunity to do as much within health as we'd like to, but for example, we've looked at enhancing the role of women in male-dominated industries, for women in leadership positions, as well as enhancing entrepreneurship and livelihoods. We have open source manuals that you can get my email at the end of this talk. I can give you the link for you to download these at their full curricula. We've also worked with micro and small entrepreneurs in collaboration with the work in Uganda. And we've created a trauma-informed personal agency training focused on victim advocates as well as care providers in high-risk settings. In Indonesia and the Philippines, we created a focused business and personal agency training for actors in the solid waste management field. And that's also been shown to increase not only self-confidence and relationship building skills, but also increase the amount of tonnage waste these actors were able to collect. We are also doing some innovation um, in order to help improve the fidelity of our trainers through scripts, tips, and audio recordings, as well as using artificial intelligence to help create scenarios to prepare for various different situations. And it allows us to enhance the process for customization and adaptation. We also have digital messaging and media with reminders and for mentorship and coaching. And all of this innovation is really designed for us to be able to go more directly to scale. So our goal is to really support dynamic interventions that center on people and catalyze development impacts. So with that, I'd like to say a little bit about our global team. We have trained over 300 certified trainers in 24 countries, working in over 120 organizations, and we have reached over 140,000 people with our personal agency training. So with that, I'd like to thank you for listening. I'm going to stop sharing and we'll go back to address any questions that you may have. Yes.
Yeah.
Okay, great.
So thank you so much, Anita, Nuraj. That was really incredible, amazing. I was thinking as I was seeing Anita speak how the two talks that you have are so different, but in the same, they complement each other in practical ways. And I think it's even for us being in Brazil, we come from a middle income country. We have a gigantic geographical space and with so many different cultures and everything. We have a public health system with so many challenges, as you probably know. And I think it's impressive how brilliant ideas, and I think that from the many things that you exposed here to us, I think the most inspiring thing for me was how you can do so much with not so many resources. And so when you have a nice idea, you can multiply what you have through empowerment, through detection, through text messages, which is something so cheap, right? So I think,
Right.
thank you so much. I didn't tell you, but this audience here is most from medical students, nurse students, general health, and they have a big role in the public health system in their cities already since the beginning, right? So I'm sure that they have many. They're living here with many ideas on how to change and starting changing the community from what you talk. And also, probably you talked with Daniel and Paulo earlier. One of the fields in CISME that we are working together with Unifage, Unimax is implementation science, and we
Yes.
are implementing some new programs that we didn't have before. But I think looking at what you did, I think many other ideas are yet to come, and we have so much to learn from you. Thank you so much.
Great.
Thank you.
Yeah, thank you so much, Arthur. I don't know if there's any questions that people had. If they're able to ask questions, we're happy to.
Yeah, the questions were not so clear because we are doing this YouTube session and it's not so easy to ask questions there. But Mariana Ferreira asked one question to each one of you. So Mariana asked to Anuraj, what do you recommend to a country with Brazil's dimensions and diversity when implementing an integrated person-centered system?
Yeah, that's a great question. I think that Brazil, I think particularly, with its primary healthcare system, um, right now they're really trying to integrate this primary healthcare with also referral services, secondary care, and with the multiple frontline health workers. I think Brazil is a very, very good candidate to create this integrated team-based care. So you have this sort of single health record at the primary healthcare center that, in fact, when someone comes in, whether she's a pregnant woman, whether it's a child, get early childhood development services or immunization or anything, that in fact these community-based workers or other workers at the primary healthcare centers, they can clearly know what that individual's had received before, what their care plan is, what services they should receive. So I think that's sort of the next level that would be very useful to do here in Brazil. And Brazil has made a big investment into the FHIR HL7 data standard. There is a working group. There's a FHIR working group here in Brazil. But I think that the challenge is that they're still not fully connecting information through some of the different primary healthcare initiatives. So I think now is a really good opportunity to do that. So that's what I would suggest. I think that's one of the biggest gains that could be gotten at this time.
So you would say that the priority, you would say, would be monitoring and connecting the systems that we have in different parts of the primary care system, especially.
Yeah, I think that's a high priority, but and then along with that, immediately start to look at that data. So you have to have situations where you're immediately gathering that data and then analyzing that to understand what are the patterns, which care is not being given, what's the quality of that, care, and then being able to target actions, for a specific, care gap. So one of the things always to keep in mind is this Pareto principle, which is essentially, basically 80% of the problems are coming from around 20% of the sources. So again, identifying those with relatively little effort, you can really improve the quality a lot. And then the other thing I would just say in general is that, I think one of the main things we underestimate in primary healthcare throughout the world is how much of a difference the quality of that health provider is, that individual. Do they like their work? Are they understanding the importance of that? Uh, you know, so the quality of that individual, and not only their skills, but their attitude toward their work is extremely important. And I think we underestimate really how important that is. So I would focus a lot on use of information to feedback to these frontline health workers to provide coaching, all of that. Yeah.
And learn how to motivate them and how to keep them
Motivate. Yes,
engaged, right? Yeah.
actually, yes. This whole agency intervention, I
Yeah.
think, is really interesting in that context. Yeah.
So we're trying to both get at agency from slightly different ways, but same goal. The same
Yeah.
goal.
Yeah. Great.
And
Yeah. You had a second question for Anita specifically, I think.
yeah, so Anita, how do we balance personal agency with obstacles and frustrations, like owning, for instance, right, owning my healthcare plan, but facing lack of supplies even in the private system. So how do you suggest, and what's your experience from other?
Yeah. So, you know, it's a great question, and we all are facing these kinds of challenges in many different areas of our lives. And what the healthcare system has tried, and also very many development programs have tried, let's try to increase the access to resources and so forth. But what we have found was, in fact, it was our limiting beliefs that prevent us from even taking the risk, because we can't get over the fear of, what if we get rejected? What if they say something and we feel bad? What if they make us feel inadequate? Maybe I don't even feel like I deserve to go get care. In many of the resource poor setting areas that we've worked in, and especially for women, they're the last one to think about themselves to get that care. Let me think about everyone else, but not me. And so that shift has to happen where each and every one of us recognizes our own value and builds that psychological engine for our own worth, and assessing, well, why am I taking advantages of this opportunity or not? Or how am I dealing with the frustration that I have around this resource constraint? Am I wasting my energy being angry? Or should I let that go and focus on what I can do? Is there another way that I can get to my goal that doesn't rely on this resource? That's the key, to help people understand that actually they have a lot more power to shift their thoughts in a direction that will lead to some better hope, rather than spending that energy, psychological, spiritual, and physical energy on getting very frustrated, unless that frustration leads to more clarity and focus. But the key is to, okay, this is my situation. This is the self-awareness that I have. What do I need to shift? Is there a way I can shift the way I'm thinking about it to get to the goal that's important for me? And then see what the next step I'm willing to do that.
Yeah, I see. And do you think this change of mindset, I would call that, do you think that you believe it's more a bottom up approach, in the sense that everyone, like you said, should, or do you think we should start with stakeholders and
Yeah.
people that shape opinions for them? We
So,
are a big population. You work with big populations
yeah,
too, very heterogeneous, and sometimes we face with the fact that even people on the top
yeah,
do not have this clarification, right?
right. I think everybody needs it. Everyone needs it. We've worked in organizations, we've worked in communities. Everyone can benefit from this, but individuals need to be open to be able to do that. And so what I found is that how much education you've had, how much trauma you've had, what your background is, doesn't impact on your ability to understand these fundamentals about how you make decisions, and be able to reframe that mindset into more of a growth mindset. The key, however, is to have people who can translate these concepts and ideas that are from the local population you're working with. So even when you have leaders, say if you're working with leaders, okay, find those that say, hey, listen, for your other leaders that are you, for example, in the case of women that are coming into leadership positions, they're with a lot of other leaders, but they may not have their own self-confidence. But if you have a woman who's gone through this training and say, listen, I used to feel like an imposter, but I realized I was doing this in my head. I don't have to think about that. What is the vision that I want for myself and my company or my organization? And that same process and idea happens at the leadership level as it does to the woman in the village who is wondering, okay, I don't have any power to leave my house, but I want my child to get this medicine. Let me try a different way to speak to the person, the head of household, my husband or my uncle, to let them know that this is important because I feel that this is important. And then let me try different ways to communicate it. So again, it's just finding one's voice and using it.
Perfect. Thank you so much, Rita, and thank you, Anuraj. It was really amazing. We are about time now.
Yes, yes, sir.
We passed a little bit,
Yeah, sorry.
but it was really, thank you so much. It was really changing and impressive.
Yeah, it's our pleasure. Thank you.
Enjoy the night in São Paulo.
Yes,
Thank you
we
so
will.
much.
Bye-bye.
Thanks, everyone.
Bye.
Bye-bye.
Bye.